Well, hello and welcome to the Glaucoma Australia live Q&A brief on Glaucoma Week. It's my pleasure to be presenting this Q&A this afternoon, this evening, or whenever you may be watching. My name is John Ruddle, and I'm a glaucoma specialist and a paediatric ophthalmologist based in Melbourne. Without further ado, I'll get through some of my information slides and then open up to the Q&A, and looking forward to the discussions that we can have. Childhood or congenital glaucoma comes in really three main types: primary childhood glaucoma or primary congenital glaucoma, the secondary glaucomas of childhood, and glaucoma that follows early childhood cataract surgery. The primary congenital glaucoma, or PCG, primary childhood glaucoma, presents in a characteristic pattern, but very rarely, and it can feature a triad of children with teary eyes, light sensitive eyes, and blepharospasm, where they are blinking their eyes and really light sensitive. And the hallmark of this condition is enlarged eyes. The children have eyes that are above the average size, and children as a whole have large eyes. When you're born, they're proportional to your head and body size. Your eyes are quite large, but these are even larger. It's typically a bilateral condition, but not always. Slightly more in boys than girls, and usually first presents before children are 6 months of age. So it should always be suspected by primary carers, by the GPs or the optometrists that are consulted about this, if a child buries their face and won't allow any examination whatsoever, even when they're rested and well fed and being entertained. The hallmark of the examination is also corneal clouding, as shown in this little picture, where an infant will have cloudy, really opaque, hard to see through corneas. It's hard to pick the color of these eyes as a parent or as a caregiver. Another clue to primary congenital glaucoma may be a very unequal refraction or a different asymmetrical eye size. And when we go looking deeply into these eyes, we look carefully for the asymmetry or the degree of optic nerve change. We also, as everyone will know in glaucoma, try to measure pressures, but it's not always that easy on these youngsters. If a case of childhood glaucoma is diagnosed, we soon get on to treatment, and medical treatment is the first line treatment that we use. Some of the drops will be familiar to anyone who has adult onset glaucoma, but there are other agents that we can use for a temporizing type of approach to get the pressure down, to explain the diagnosis to the parents and the family, and to get on and perform surgery, which is the mainstay of the management of this condition. And it's been asked, what is the youngest age that a child could have eye surgery for glaucoma? Well, as early as the first month of life. If it's clearly high pressures and corneal clouding, then yes, I perform surgery on infants that are as young as 1 week of age. And we wait only long enough to be certain of the diagnosis and to see the effects of some of the early medical management that can be undertaken. Really, I thought I'd discuss, and these could prompt questions later on, but how does childhood glaucoma differ from adult glaucoma? Well, of course, there's a wriggly kid in front of me that I need to engage and obtain as most information as I can in as quickly as possible. And so taking their pressures is a challenge, and thank goodness that as I started to get into this field a decade or 15 years or so ago, the eye care rebound tonometer became available. Also in childhood glaucomas, it's more likely that we are going to track down a genetic cause than in an adult onset form of glaucoma. Other challenges include refractive problems that arise from such big eyes, or amblyopia, which is lazy sight that evolves when the eyes are not corrected by glasses, or that the brain decides to use the better eye, not the one with more glaucoma. And that is a challenge for all children with glaucoma up until the age of 7 or 8. Surgery is a greater part of management of childhood glaucoma than it is in adult glaucoma, though anaesthetics might be only needed just to look at a child under asleep so we can get a very good idea of what's going on. In general, I'd say the surgery is more challenging in these eyes, and it's not just because we're dealing with little people, but we're also have tissues that are a little bit more malleable and a little bit more flexible, and so they're less forgiving to the things that we're doing. And also, we need to care for the whole family with this condition, and it's not just the patient, but we need to remember that we're looking after the patient, their family, and their siblings, and are all going to be involved and impacted by this diagnosis and the management of this condition. Taking a pressure in a child, as I mentioned before, takes a very cooperative child, and I'm not sure that they ever look like this photo, sitting still and smiling or serenely looking at the eye care tonometer. It's usually an entertainment in the background, a parent doing a dance, some cartoons on the iPad. But whatever we try and do, we really want to get a tap of the pressure on the eye and an idea of where we're sitting. And now it mightn't compare exactly to the gold standard, but it is certainly the best way we have of measuring a mobile child's pressures. And these can be done under anaesthetic as well. I mentioned that genetics is an expanding area, and I know that colleagues that have scientists and clinicians that work in this field have talked previously at other Q&A events. But there are a large alphabet soup of different genes that can be involved in primary congenital or primary childhood glaucoma. And we're learning more and more about the origins of glaucoma by understanding how upsetting these genes in a big way could lead to glaucoma. It's interesting also to make the leap that if you make minor changes in some of these genes, then you could have an adult onset form of glaucoma as well. But by and large, childhood glaucoma we can think of as being a 1 or 2 gene disease caused in each patient by 1 or 2 genes, whereas in adults are more of a multi-genetic form of the condition. Okay, so we take on a child who has congenital glaucoma, we use drops, we perform surgery, and typically the surgery is either angle surgery, where we incise the angle of the eye, or we perform trabeculectomy or tube surgery. So the mainstays of glaucoma surgery. We don't tend to use mixed devices, and I can talk more about that in the Q&A session. Once the glaucoma is controlled, what do we do next? Well, it's important to keep up the monitoring. Obviously, even though the surgery might be successful, it can slowly lose its effect, and we need to monitor the pressures and the development of the vision. We also need to assess the child as a whole. Has the period of glaucoma affected their development? Would a pediatrician be helpful? And especially finding professionals, speech or physio or OT, that have experience in those with variable visual function is quite helpful in this follow-up. We don't perform field tests on little children. The youngest that we start doing field tests tends to be around the age of 9 or 10. Though probably from the age of 3 or 4, we're trying to take photographs of optic nerves, and from 4 or 5, trying to take imaging in the form of OCT scans of the optic nerve to be able to really just monitor the health of the back of the eyes from the effect of the glaucoma. What's tricky about doing that monitoring is that you need to factor in the effects of growth as well as the possible effects of glaucoma. As I said before, going on with a case of childhood, in a childhood glaucoma, we need to monitor and provide patching therapy for amblyopia or glasses therapy. And we also need to provide the holistic family support that it might involve some genetic counselling. It might involve carefully supporting siblings who are dealing with a sibling with glaucoma who's having frequent checks and a lot of medical attention. I mentioned the three major types of childhood glaucoma as a primary glaucoma. Secondary glaucomas is really a big term to describe several different, or many different subtypes of glaucoma where we can pin down the cause as either a syndromic systemic disease like Marfan syndrome or neurofibromatosis, or a Sturge-Weber, which is a port wine facial birthmark associated with glaucoma. It could also be a secondary glaucoma associated with an acquired condition. Could that be an inflammatory uveitis in the eye? In young children, that's unfortunately not an uncommon cause of glaucoma. Could the child have had trauma, an injury that's led to damage to the pressure controlling mechanisms of the eye and secondary glaucoma? And there's also those that can have pressure-induced effect from the use of steroid drops for another condition, be that allergic eye disease or a systemic condition needing immunosuppression with steroids. Finally, there are also developmental eye conditions that lead to glaucoma early in life. And one of the umbrella terms to describe this is anterior segment dysgenesis, or the front of the eye, the cornea, the iris, and obviously the fluid draining mechanism near that not developing properly. And that is sometimes known by the term Axenfeld-Rieger syndrome, but there are other conditions, sometimes aniridia or Peters anomaly, that could also lead to secondary glaucoma, and are usually termed under this glaucoma secondary to associated ocular anomalies. Finally, the third group of children that I treat with congenital glaucoma, and that make up, as you move through the ages following children, make up a bigger and bigger proportion, are those that have raised intraocular pressure or ocular hypertension, or glaucoma following cataract surgery as an infant. It's the major long-term complication of infant cataract surgery. In our numbers in Melbourne, it tended to occur in a little rush in the first few months after surgery, but then steadily increasing as we followed these children for longer and longer, so that up to 10 or 15 years after surgery, there's about a 30% rate of glaucoma occurring in these eyes. And the risks seem to increase in our series when intraocular lenses were placed in these eyes. But that's a very fraught or messy area for understanding, and the risks of each individual having cataract surgery for getting secondary glaucoma can be a little bit predicted, but it often needs to be individually discussed. What do we do to avoid glaucoma that follows cataract surgery as a child? Well, we need to time the surgery. If you're an infant with child onset cataracts, it's better to wait at least 4, better even 6 weeks of age before surgery is done for cataract. That way, your lifetime risk of glaucoma is reduced. Careful surgery, careful wound care, and not implanting lenses in smaller eyes can all help to avoid secondary glaucoma. And also avoiding lots of post-operative inflammation is helpful. It's not quite clear really whether the intraocular lenses in larger eyes or normal-sized eyes could prevent or slow down the onset of these glaucomas, but big cohort studies are being performed. And of course, if you've had someone in the family who's had cataract surgery as a child, and that's under 1 really, they need to have yearly careful monitoring. So the take-home messages from this part of my presentation really is that childhood and congenital glaucomas are rare, but when they happen, and if they are in your family, it's important to discuss personal risks and the risks of siblings with ophthalmologists involved in this area. That the sight-saving surgeries and treatments are available and are improving, and I'm really excited working in this area to have seen the advances in genetic studies that may hold future promise of future targeted therapies aiming at specific genes and the issues that they cause. So I'm very happy to take further questions and continue this discussion. I've just had the one question come through on the chat. In the case of congenital glaucoma, is there an age before which it is essential to have glaucoma surgery to have a good prognosis for functional vision for the future? That's a great question. I think that there is Certainly before the eyes become too asymmetrical or too large, you know you're going to have a better chance of controlling the pressures with long-term excellent vision. So if many, many months pass with aggressive pressure, with poor pressure control before the condition is diagnosed, it is a trickier situation to come back from, to save vision and to keep the stronger vision. The refractive problems that arise if it's a very unilateral disease, the amblyopia I talked about, the fact that one eye might be -10 in its focus and the other eye only +2 can be very tricky to deal with. So that's why the bigger eyes are trickier. If both eyes, though, have marked disease, sometimes we can treat them simultaneously, aim to get the pressures down very evenly, and you can retain good vision in both eyes. So there's no set age. It really depends on how quickly the pressures have risen and what the effect of the pressure is on that particular eye. And although glaucoma robs elderly people of their vision by damaging their optic nerves, childhood glaucoma is a different mechanism. It can damage the eye from the front with corneal scars and stretch marks, with dislocated cataracts with this high myopia, or it can damage the nerve and cause high myopia and the risk of future retinal detachments as well. So that's a very long answer to that question, but saying that there's many things from the front to the back of the eyes that need to be taken into account to slow down childhood glaucoma, early onset glaucoma, and to prevent it leading to vision loss. Another question I see there is that it's almost impossible to get an eye pressure checked for my 18-month-old. How do we diagnose it when their eye pressure reading could be so inaccurate? Wow, that's the toughest age. That's the age that strikes fear into me. Maybe a 2-year-old that's really wised up to attempts to take their pressure, doesn't like things coming near their face, has got a dose of stranger danger, let alone someone trying to wear a mask and wave a funny device near their eyes. I think it comes down to what is the risk that we think, and whether with distraction and taking a dilated look at the eyes, whether we think that there is a high risk of glaucoma or not. If I think that there are features that are strongly suggestive of glaucoma in an 18-month-old, but I can't take their pressure, I will arrange an examination under anaesthetic. If it is a less risky scenario, maybe I got a pressure 3 months ago and I'm really hopeful I'll get one again in 3 months' time, and the child performs well with the vision acuity testing and appears to have a healthy nerve and everything else in the eye seems to be the right size, I won't be so worried about one examination where I haven't managed to get the pressure. And that's with an eye care. You could also get a sense of what the pressure is through experience, through palpation of the eye. So yes, there are different ways of taking pressures, but you certainly pick the difficult age group if you're trying to look at an 18-monther. Are there cases where congenital glaucoma can be treated with just drops and not surgery? There are, but they're rare. They tend to be the secondary glaucomas. So maybe an eye with a little bit of an injury that's got some problem with its pressure regulation, or in rare events, congenital glaucoma can present and burn itself out. And I wish I could understand that more, but sometimes you can meet an older person who's got features of congenital glaucoma, a little bit of an enlarged eye, a couple of stretch marks on their cornea, and yet they see very well and their pressures are normal. And that we call burnt out congenital glaucoma. Now, they have a lifetime risk of returning to true glaucoma, but that sort of eye may be managed by just medical therapy, just regular drops. Possibly, to roll in the next question as well, can SLT laser be done as well? Yes, you can do laser on the trabecular meshwork of children's eyes, though they need to be cooperative and awake and able to sit themselves up at a slit lamp. So probably from the age of 7, 8, 9 onwards, in a cooperative girl, maybe. The boys, if they're a bit wild, but it might take an older age. But the SLT can be quite effective in children's eyes, and smaller doses than adults generally would be used. You can't use them though if the angle looks abnormal if the angle of the eye, the area that the laser is applied, the junction between the cornea and the iris, isn't open and appearing to have a normal trabecular meshwork. Another question there is, what is the most common complication following glaucoma surgery in children? I think I often, when I'm talking to parents about this, divide them up into early risks and later risks. And the early risks are things like discomfort or low pressures that cause blurry vision and maybe cause some irritation. You can have little bleeds in the eye, or an eye that needs to have more patching because it's had a month or two where it's been blurry after the surgery. But the most common complication would be that the glaucoma surgery slowly scars or fails, and that's really what we call a late complication of glaucoma surgery. So whether we've done a trabeculectomy or an angle surgery or a tube surgery, the later complications are that those are not enough to maintain the pressures at the low target pressure we're aiming at, and that further surgery may be needed. There's a good question about using and the difficulty of using post-operative eye drops. And if it's difficult, is it harmful to my child's eye? And are we risking the surgery being unsuccessful? I think that every child varies a little bit in their ability to take eye drops, and those that are at the really wriggly age, and we know those that are very apprehensive or anxious about things being done to their eyes will fight back and make it very hard to give these eye drops. And I think it's a very good question to raise with your treating surgeon, because there are things we can do to minimize the amount of drops needed afterwards. Perhaps we can give a little depot of a steroid medication under the eye or around the eye at the time of the surgery to help. The other thing that I try to instill in parents is that if you are using the milky steroid post-operative drops and a child is able just to gently close their eyes, often they can blink the drop in. If you've placed it on the corner, on the inside of the eye, you will see that milky drop track across the tear film across and into their eyes. But I think if you are having a really hard time with doing these drops, the other discussion you can have with the treating surgeon is about maybe cutting out an antibiotic drop very early on after the risks of any infection have well passed, and using maybe a drop at night time when a child is asleep, or using a cream when a child is asleep. That's a bit of a slow release is another option you've got as well. Next question, would the MIG surgery that's done on adults work on kids? What a great question. And wouldn't I love to have the answer to that one? We know that MIG surgery, or minimally invasive glaucoma surgery, involves trying to utilize the more natural outflow pathways of the eye. And the little devices that we implant are either just placed into the angle, or indeed actually do cross from the inner chamber of the eye through the sclera and under the conjunctiva. I have never read a successful study or attempted to do just angle MIGS surgery on kids implanting devices like an eye stent or a hydrus. However, there is an ability to perform 180 degrees or 360 degree angle surgery using a MIGS type device called the eye track cannula, which I use on children's eyes. And there is good evidence that the eye track device is a little more successful than treating a smaller area with goniotomy. So certainly it's an active space of research, and there are some MIGS devices that are potentially useful. For the full thickness devices, I think I have a natural reluctance to use them when I know that scarring still bedevils these full thickness MIGS devices, and that the scarring leads to higher outcomes, higher pressures and less low successful pressures than trabeculectomy. So there is some work being done on the PRESERFLO device in children's glaucoma. I'm aware of those studies, but it's not yet, I don't think, proven in our armamentarian or our treatment paradigms to treat surgical children's glaucoma this way. Another question here: if early diagnosis of childhood glaucoma gets missed, is there an age by which treatment is needed to save some vision? It's a very tricky area because it depends if the glaucoma was aggressive and high pressured, and what degree of damage was occurring to areas of important for sight during the time that it was missed. It's really hard to put an age or a duration on that, because if say childhood glaucoma was slow burn and the pressures were say 25 and that was doing a mild amount of damage, or 30 say, and that was missed for a year, there'd be a lot less damage than if pressures were 45 and missed for 4 weeks. So it depends on the degree of pressure rise and the age at which it's occurring, and whether they've been partly treated or not treated, or what the cause was. I've got another question here from Renee. Thank you. What are the typical developmental issues that may occur for congenital glaucoma, and what age is support needed, if needed? That's a great question. I think that most of the glaucoma we see can be associated with absolutely no developmental issues. So not necessarily do all the genes that cause childhood glaucoma lead to developmental problems as well. But when you start having a problem with vision, or if the glaucoma leads to complications with the vision, then, or children are held back because they've been having surgeries or drops, or they're missing out on some of their early childhood learning, then you can find that there are some delays in some of their motor skill acquisition, or in some of their developmental trajectories. But many children don't need support if their vision is good, especially if their glasses bring that vision right up. And I think I was answering that. I think that if the children are missing out on a lot of their early input, then you can involve the GP, you can involve pediatricians, and they're very good at making an assessment of whether it's just other illness-related delays, or whether they're concerned that there are other underlying reasons. And of course, many children can have developmental issues completely separate to their glaucoma diagnosis. So they need to be considered if you're worried about a child's progress. And the other thing to say is that children, and perhaps this is the cohort of children who've had childhood cataract, that they need really excellent visual rehabilitation with contact lenses or glasses from a very early age, and they might often be doing a lot of patching to try to keep the vision up in their weaker eye. And in those situations, the children will be having more difficulty, I guess, with their fine motor skills and with some of their proprioception and even gross motor skills as they make their way through those milestones. So it's useful to have a chat to your ophthalmologist if you're worried about that, and to get around you a team of a GP with interest in child health, or a pediatrician who can track and let you know how the development is going. Another question here about if my child has an eye injury, say a ball during play, should I be taking him to get his eyes tested in case the eye pressure has gone up? Most of the time, a injury sufficient to damage longer-term eye pressure control will result in a visible bleed inside the eye or a change in the shape of the pupil, or enough of an injury to put a cut onto the eye, or great significant bruising around the eye. So I think if it's an injury where you suspect those sort of things have gone on, absolutely, it's good to know if the eye pressures were up at the time of the injury. And then sometimes an optometrist 6 or 12 months later could be looking at a child who's had an injury from a ball sport, just to double check that the pressures are still well within the normal range. Unfortunately, normal eyes have quite a robust mechanism for maintaining their pressure within a normal range. Another question about a port wine mark related to glaucoma. Is this just glaucoma or other eye and health conditions as well? It can be just glaucoma. You can have these birthmarks, which are abnormal blood vessels in the skin around the eye that lead to raised pressure in the system trying to drain away the eye pressure. And that backs up, if you like, backs up to cause pressure inside the eye. So if it's a subtle port wine stain, it could cause glaucoma, and it could even happen 10, 20, 40 years after in someone who has this type of glaucoma. If there's more prominent birthmarks or bilateral, both sides of the face, there can be an underlying condition known as Sturge-Weber syndrome, where there is also a risk of seizures or epilepsy, and also some of these abnormal blood vessels around the lining of the brain, and that can lead to developmental problems as well. But that's the severe end of the spectrum of a mild port wine stain, and many port wine stains, if they're away from the eyes, are no risk at all to causing glaucoma. However, if you know someone, or if you've had a family member with a port wine stain that involves the eyelids, it's always worth having a yearly pressure check to monitor for glaucoma. Well, I think we've covered quite a bit of ground in this live Q&A session, and I hope that I've answered many of the questions. I look forward to hearing the feedback, and as always, members of the Glaucoma Australia community are invited to submit by email their questions and to search on the other resources on the website for answers and further knowledge. And I hope this has been helpful for everyone that's been able to listen along live today and in the future to the recording. It's been my pleasure to present.